Assalamualaikum dan selamat sejahtera to everyone, to all the participants that join our virtual health talk today, empowering women to a greater healthcare and to know the importance of mammogram and gynecological screening with UiTM Private Specialist Center. Without further ado, let me give you a little brief about UiTM Private Specialist Center. We are established in the year of 2016. UiTM Private Specialist Center is managed by UiTM Private Healthcare Sdn Bhd, a wholly owned subsidiary of UiTM Holdings, and UPSC offers a comprehensive healthcare services to its patients at a competitive rates considering all sections of general population in Malaysia. We are driven by our core values of unity, proactive, safety and care. UPSC is a family-centered hospital that provides a one-stop healthcare solutions to everyone. It provides cost-efficient and high-quality healthcare services through excellent medical expertise, assisted by the latest state-of-art technology. We are as well, of course, dedicated to set the standard in value-based healthcare through our visions, which is care, achieve, and innovate. For instance, we are the first to bring in the robotic-assisted surgery in Malaysia. Every members of our team is a very skillful and well-trained, from surgeon to specialists, from nurses to frontliners, who work together hand in hand to ensure the best course of treatment for each patient and within the comprehensive and peaceful environment. And with us today is two of our speakers, which is the first one is Dr. Nazimah Mumin, a radiologist and also an expert in breast imaging. The second one is Dr. Noorneza binti Abdul Rahman, a gynecologist and also obstetrician. Okay, so now Dr. Nazimah Mumin is a medical graduate from Leicester University, United Kingdom, and had been serving HUITM Selayang Hospital Sungai Buloh, University Malay Medical Center, UMSC, and as well as currently serving UiTM Private Specialist Center. She is specialized in breast radiology and imaging and well educated and equipped with high knowledge of breast abnormalities and cancer. With many years of experiences in the field, she is trained to be among the best in her field. Okay. Without further ado as well, I will pass the virtual health talk to Dr. Nazimah Mumin.
The two breast plates, okay? A little bit of pressure, but you will not feel any pain. You shouldn't feel pain. You should feel just slightly discomfort, like someone is pressing onto the breast. That's all. Right. So there are two types of, well, there are a few more types, but the general one is for screening, which is why we are here. I'm going to talk about screening mammogram and diagnostic test. So for screening mammogram is for women who has no sign or symptoms, meaning you have no lumps, you don't have any nipple discharge. Voluntarily you come so that if there is anything that is not yet detected, we can help you find out if there is any abnormal growth or abnormal calcifications in your breast before you can feel anything, before there is any symptoms that are noticeable. Diagnostic mammogram is when you already feel a lump or there is already changes in your breast, or you feel a mass, or there's nipple discharge, anything. You went to see the doctor and the doctor say, okay, we need to have mammography done. That is diagnostic mammography. It's the same machine, same sort of investigation, but to investigate different things. So the best if we can detect lesions during screening when it is not big enough and you have lots of other treatment options to treat the breast cancer. If it is cancer, not necessarily things detected with mammograms are cancer. It can just be a benign changes, okay? So who needs mammogram? In Malaysia, if you look at the latest clinical practice guideline by Kementerian Kesihatan Ministry of Health published in 2019, screening mammography is recommended every 2 years in women in general population between the age of 50 to 74. But if you are above 40 and you want to have your breast screening examination performed, we will still accept you because above 40 is what recommended in the America. So they start screening every year for everyone above 40. But in Malaysia, we recommend 50 and above. But if you are above 40 and you want to have it done, no problem. you can have mammogram done as screening. And screening should be continued for even above 70 years old, so long you are in good health, you doesn't have any uh, diseases that will cause your life to be less than 10 years, or you don't have any severe comorbidity, you are bedbound, and that those reasons. Screening is so that we can prolong your life, and so that you can have a higher quality of life. So now for these two parts, it's for women who are high risk of breast cancer. Who are women who are at high risk? They are women who has family history of breast cancer. Okay, but you have not had any genetic test identified yet, or you've not had it tested yet, but you've got close family members who are diagnosed with breast cancer at a younger age. For example, your mother, sisters, siblings. So these women are encouraged to come earlier for the screening, and it can be considered from 30 to 39 years old. And every year, it's different, yeah, for general population every 2 years. But because these women have high risk, so every year from age 40 to 59, and every 2 years from 60 onwards, because then it will fall down to sort of a general risk. But if you are known to be carriers of genetic variants, for example, BRCA1, BRCA2, PALB2, there are a few other example of genetic, you will be told if it was detected in your genes. You have to have, on top of mammography, annual MRI too from the age of 30 onwards, and the mammography will be annual from 40 onwards, and if you achieve 70, then 70 onwards, and you need to come and see a specialized genetic clinics for breast cancer. Yep. So, who are at risk of breast cancer? Some, or from that, we know that if you have some sort of genetic predisposition, then yes, you are high risk, but we can separate it into non-modifiable risk for breast cancer. Non-modifiable meaning you cannot change it anymore. It's something that's inherent to you. For example, your age. The older you will get, then the risk of developing breast cancer will be higher. The risk of breast cancer increases from the age of 25, and the peak of age for breast cancer is 60 to 64. So that's why Malaysia recommend screening 50 and above, so that we will catch it before it becomes bigger and metastasize, goes everywhere else in your body. And gender, can't help it, like you are born a female, so that means that we all as female have higher risk of breast cancer. I've mentioned family history just now. So if you've got any family members with breast cancer at a younger age, or if you are known to have family members who are genetic carriers of all these BRCA1, BRCA2, PALB2, ATM, CHEK2 genes, then you will have that risk too. Reproductive factors, if you will get menarche means if you've started your period earlier at a younger age, or if you had your menopause at a later age. Usually more 50 is the age for menopause, but if you are 50 plus 60 years old and you're still not menopause yet, then you have slightly higher risk of developing breast cancer. If you have history of neoplastic disease, meaning cancers of the breast, you had biopsy done before and they said, oh, you have DCIS, ductal carcinoma in situ. It's not yet cancer, but it's a type of cell that can develop into cancer in the future. Atypical ductal hyperplasia, the lobular hyperplasia. These are a few examples of tissues that are detected in your breast. And if you have them, you have a higher risk of developing breast cancer in the future. Breast density is another risk that you can't change. You are born with this type of breast. If you have higher density of the breast cancer, then you have higher risk of developing breast cancer. Density is detected from mammography. Modifiable risk factor for breast cancer are breastfeeding. Okay, breastfeeding, if you had previous babies that you've breastfed, you will reduce your risk of breast cancer. Nulliparity meaning if you've never given birth, you're not married, or you're never married, or you've never become pregnant, you've never given birth, then you have high risk of breast cancer too. Hormonal factors includes if you've taken oral contraceptives before or on oral contraceptive now, or if you are on any hormone replacement therapy. Again, the hormone itself is give you a small risk factor of developing breast cancer. Overweight or obesity throughout adulthood is a risk for breast cancer because the fat tissue will produce estrogen, and that is the same sort of with the hormonal factor. Radiation exposure, if you've had lymphoma at a younger age and you've had radiation to the chest region, so that will increase your risk. You can't change all this. These are the factors that you can change, but of course, if you've had them, you can't really change your risk. You still consider as a person with slightly higher risk of breast cancer. So now we move on to talk about mammogram and what are the risks of mammogram itself. Okay, mammogram is the examination that I've explained earlier to you to image breast tissue. It involves radiation, but the radiation given through mammography are low dose. It's even lower than the dose given for chest radiograph or CT scan. It's not that high. It's very low dose and it's very focused just to the tissue that we want to image. But the results from the mammogram sometimes is not 100% accurate, especially if you have dense breasts where there are overlapping breast tissue. It gives difficulty for the radiologist to interpret it accurately. So you may ended up having to do more tests, for example, ultrasound, which does not have any radiation exposure, or MRI or biopsy. If we found something and we are not sure is this something serious or not, of course we will offer more tests to be done. In younger women, especially, again, because of the density of the breast is high, it's very difficult to interpret mammography. Like I've explained, it may lead to additional testing. It could be just ultrasound to reassess areas of the breast that is not clearly visualized, or more views for mammogram. For example, just a small part of the breast will be recompressed again and re-imaged, or biopsy or MRI, depending on what type of abnormalities found by the radiologist. And not all cancers can be detected from mammography. There are other types of cancers which does not give clear signs in mammogram to say, oh, this is cancer. So again, you may ended up having other tests too. And not all of the tumors found by mammography can be cured. Okay, like I say, screening will help us detect the cancer when it is still small, when it has not spread. So those who are detected earlier has higher chance to be cured. But those who presented later, where the cancer has already spread to other organs, or it's a late stage, or it involves the whole of the breast, so it can't be cured anymore. So that's why we always promote screening to detect cancers when they are early and not yet spread everywhere. Okay, now if you decided one day to come for screening mammography, well done, very good. How do you prepare? First, choose a certified mammogram facility. Means that when it is a certified facility, the mammogram machine will undergo QA, quality checks, and have already been licensed, and the operators are well trained, and the radiologists are specialized breast radiologists. So you will not have a wasteful test. You go and in the end, it's not interpretable, or it will give false results. So you don't want to waste your time and money and effort and radiation to the breast for something that is not helpful to you. Okay, and schedule the test of the mammography to when your breasts are less likely to be tender. We all have menstrual cycle, and of course certain time in the menstrual cycle, for example, just before your first day of period or earlier in your period, you will feel slightly tender anyway in your breast. So it's better to schedule it when you know your own breast, when you know it's less tender, especially when it's not related to your menses. If you already have mammograms done before at another center, it is always advisable to bring these images or this report or this CD or whatever, but bring it on the day of examination so that the interpreting radiologist will be able to compare. Because sometimes if we see a finding, it may already been seen before. So we don't have to order more tests or subject you to biopsy if it's already something that is stable for years and years and years. So it's always very useful to bring that information with you. And do not use deodorant before your mammography because that will give artifacts. It will give calcifications on your skin, which will be captured into the mammogram, and it gives us again unable to interpret because it will covers the area and gives false positive, meaning it's not there, but we thought there is some disease there because of your deodorant. So don't wear it on the day of your mammography. Okay, this is how it will look like. Yeah, so this is your right breast. We will always do these are the standard views. This one is where the machine will be tilted so that we can image some parts of your axilla. This is your armpit area. This is important area to be included because we want to see also the lymph nodes. It will be seen here. And this is the breast tissue. This area here are the breast tissue. And this is another view of the same breast. This is right. This is right also. So this view is when the machine is straight, like when I showed you earlier, where the breast is compressed from top to bottom. So it will spread out the breast from top to bottom. And this view here is when the breast is compressed laterally, but it's in an oblique way, so that we will include the axilla, the armpit area. So this is the left breast. So commonly, it's just these four views required. So the radiologist will assess this, and if other views needed, then we will ask for you to have those views too, or ultrasound or anything else. Most of the time it will be normal. We'll say, okay, we'll see you back in 2 years time because there's nothing sinister here or nothing suspicious here. Okay. Now, the results, as I said, you don't have to worry. This is what we will hunt for in the mammogram. We will look for all these signs and differentiate. If it's cancer, then there are certain features seen. If it's not cancer, we can still see things. Like I said, not necessarily everything detected on mammogram are cancer. There are some like this. This is just calcified blood vessel. This is just fibroadenoma. These are just probably calcifications on your skin. So you get some findings which are benign. So not necessarily anything found in the mammogram are cancer. So you don't have to worry about them. Yep. So like I said, possible findings are the calcification, mass, asymmetry between the two breasts, dense area. Some of the dense area we may order further imaging, for example, compression to spread out the breast tissue further, or new dense area. That's why I mentioned previous mammogram is very important so that we can assess if there's any area that suddenly become dense. Has it been like that before? If it's not, if it's stable, it hasn't changed, then we don't have to worry about it. Okay. Right. So I've mentioned additional tests, for example, ultrasound. So this is ultrasound if you've been pregnant before, you've had ultrasound for your fetus, for your pregnancy before. It's exactly the same thing, but the probe is different. And now we will be looking for your breast tissues instead of your pregnant belly. So it's the same test. It doesn't have radiation. It's using sound waves for this to further assess anything that we see in mammogram. And if you have dense breast from your mammography, for example, this case that I showed, this is an example of dense breast, means you can't really see in between the breast tissue. We don't want to miss things which are not seen in the mammogram. So we will order ultrasound, which we will do in the same center, in the same setting in UPSC. So we will look at any tissues in the breast. So you'll be lying down. It's not painful at all. It's basically like your pregnancy scan. So now, if we found anything suspicious, we may order biopsy, which will also be performed with, this is the ultrasound probe. With ultrasound guidance, we will give painkiller, clean the area, and we will target that lesion straight away to get tissue diagnosis. This is another step. This will not be done on everyone, only in those with suspicious findings. Or another type of biopsy is when we biopsy with the mammogram as guidance. So there's always a few options to target any tissue that is suspicious. Also, we have MRI. For MRI, instead of lying down supine on your back, you've got to lie down prone. The breast will be in this here so that we will be able just to visualize your breast tissue. Again, this is very specialized examination only for those who need more tests or those who are carriers of those genes like BRCA1, BRCA2. These people will have to undergo MRI breast as additional tests. Thank you. I think I've taken a lot of time to explain about mammography and its indication and its risk. So I am very happy to take any questions from the floor or from you, Lynn. If anybody wants to ask any questions, feel free to do so. Thank you.
To those who would like to ask questions to Dr. Nazimah, you may write in the chat box, please.
Oh, okay, yep. I will look through the chat box if there is any questions. Or if you suddenly thought about it and you wanted to ask about it later, you can always, Doctor, how can I detect any lumps? Okay, this is a really good question. Thank you, Noor Hanatasya. So basically, the best way for you is to have a routine self breast examination, which means every month, I always say this to every woman because you have your regular monthly menstrual cycle, right? So on the day, the last day of your period, right before you want to mandi wajib lah for us as Muslims, you do that breast examination yourself. If you're not sure how, YouTube has lots of videos. It's very hard for me to show you because we are online. It's very so they will show you how. So if you do that every month, you will notice if there is any changes in your breast tissue because you've been doing it routinely, right? Also includes your axilla area, your armpit, and also nipple. See if there's any loss of symmetry, any nipple discharge. Do it yourself. But if you fall under those groups that I've mentioned, above 50 or even above 40, and you want to have mammography done, then yes, because things like calcification, you will not be able to feel that because it's not a mass. It's within your duct and it's small, small calcifications. So those things you will not be able to feel no matter how hard you press your breast, you will not be able to feel that. So for those people, the best way to detect any suspicious tissue or any cancer or anything early is by mammography because we will see that calcifications or any asymmetric tissue from the mammography. You will not be able to feel that. But having said that, still do your self breast examination because that will help you recognize and be familiar with your breast. And you will notice first if there is any asymmetry, any lumps that you detect yourself, then come to see the doctor early and we will do tests so that we will catch the cancer early. The aim for screening is you are well, you have no symptom, but we want to catch them early because if you catch them early, we can just remove it and that's it. You don't have to go through chemo, radio, and you don't, the cancer hasn't spread or everywhere in your body. Because in Malaysia, actually in the world, the highest number of cancer is breast cancer. And this is also the number one killer. Previously, before year 2010, it was lung cancer. But now it's breast cancer. And I'm very passionate about this because this affect women. And we are mothers and we have small kids and we are half 50% of the population. So the only way is to catch it early. We can treat it, get rid of it, and most of the time now, if you remove the cancer early, these women will go on and live until 70s, 80s, and they will um, pass away because of something else. For example, heart disease or stroke. At least these women have a chance to live a long, full life, not prematurely uh, died because of breast cancer. Because this is something that we can detect early lah. Okay, got another question. Doctor, if our breast continuously itchy, which sometimes feels hurtful. Okay, itchy. Now, this is very difficult for me to understand because I think itchiness could mean a lot of things, Norlinda. It's a good question. Usually, cancer will not present as itchiness. But if it's something that bothers you, feel free to come and see your doctor. Then that doctor will, of course, assess further. Because if it's itchy because there is a discharge from your nipple, then that is something worrying. If it's itchy because now you've got like an ulcer and a skin with a mass underneath, that is something scary. But if it's just skin problem, then it's probably not a symptom of breast cancer. But having said that, if you're not sure, if it's not hasn't gone away, come and get it checked if it's something that's worrying for you. Usually cancers will present as a lump, a mass, nipple discharge, asymmetry. Suddenly your nipple become inverted. It got sucked inside. Inversion, nipple inversion, we call it, or lumps in the axilla and things like that. Itchy is not really. I hope that helps answer your question. Doktor, biasanya untuk screening memang berapa persen pesakit cenderung untuk... Okay, this is a good question, Siti Khadijah. So in general population, we separate breast density into 4 categories: A, B, C, D. Yeah? A and B categories are those with not very dense breast, meaning from mammogram we can see everywhere. I mean, we can see the breast tissues very well because the breast is not very dense. But category C and D are women who has dense breast. Women who has dense breast, the problem is because the fibroglandular breast tissue are very dense, we don't want to miss things hiding in between those breast tissues. So we will always complement with ultrasound so that we check further with ultrasound in between these breast tissue. Is there anything hiding? So if you're asked about percentage, unfortunately, Asian women, which all of us are, we tend to have dense breasts. Most of the mammogram we do will have, especially younger women, you will have category C and D, means you will need ultrasound on top of your mammogram. Also, if you are young, why younger patient has denser breast is because the fibroglandular breast tissue are still present. The older you get, it will involute, meaning it will slowly go away because this fibroglandular breast tissue is important for breastfeeding, for lactation, but that is when you need it when you are in your reproductive age. So as you go older, it should go away. So that's why younger women will have denser breast and usually will need ultrasound. Also, if you have a symptom, like I said, mammogram, there's 2 types, right? Screening and diagnostic. Usually for diagnostic, definitely we will have to do ultrasound too because you come already present with a lump palpable or with a nipple discharge. We want to test it further. We want to make sure we are thorough in examining your breast. We will also do complementary ultrasound. But ultrasound is very quick. You just lie down there and we'll just quickly check through both of your breasts and your axilla and then tell you if there is something there or there's something that's not there. At least it will reassure the patient and the doctor examining. How long time taken, Hanatasya asking, how long time taken for mammography screening? What is the best time for screening session in the morning or afternoon? For how long time for mammogram screening, the time to do the test itself is very little. You just um, come, the machine will compress your breast, x-ray, that's it, done. So for right side, left side. So easily if it's there's no problem, you don't have to have any additional view, maybe less than 30 minutes, you will finish. But usually the time taken is for you to come, park, register, change, position. Okay, sometimes you tukar baju, lupa pula nak buka brides. Those are always the things that delay the examination. The examination itself does not take long. Just a few minutes and you're done. So now morning or afternoon, I'm not sure am I the best person to answer this. Maybe you can ask Lynn and the UPSC team. I think it doesn't matter so long that the best time means, for me, timing is more depending on your menstrual cycle. So that don't come when your breasts are very tender just before your periods or in the early days of your period, because we want to compress your breast. Imagine if it's tender, you will not like us and then you don't want to come next time, kan? So come when your breasts are not tender. uh, but timing pagi petang, I think pagi lah better. You still can continue your day and I think lah. But I mean, you have to ask UPSC with the timetable wise. Okay, if there's no more question, you can just leave question here. I can answer in the chat box also if we are running out of time.
Doctor, perhaps you can answer one more last questions from our participant. May
Can
I know how much would it cost to do the screening consultation?
you have to
Oh,
ask?
this one should be mine.
This is not. This is
Yeah,
not with.
yeah.
Yeah, but can you answer these
Yes,
participants
can.
later, Lynn?
Yes,
Yeah.
can. So Mazlin, for the price, it's actually RM 320. However, stay tuned until the end of this virtual health talk because we have some special rate for everyone that joined today. Okay? A
So I
very,
think I
very
want
good
to answer
price.
Azrin. Yeah, Azrin, good
Yes.
question.
Mm-mm.
Her question is, adakah breast cancer ini mengikut keturunan? Jika dalam keturunan tiada menghidap penyakit ini, adakah terdapat faktor lain yang boleh mendorong kepada breast cancer? Adakah faktor makanan boleh menyebabkan? Okay, this is a good question. Okay, keturunan or genetic memang there is a risk. Meaning, if your mother, if your auntie, your cousin, your siblings, adik-beradik perempuan ada breast cancer, you have high risk of breast cancer. Because genetic ni macam something you get from your parents kan? So, diturunkan kepada you. So, that's why orang-orang yang ada high risk ni mesti get screening earlier. Sebab kita nak catch early. Kita tak nak nanti lambat dah besar dah teruk baru kita tangkap. Okay, so ada. Tapi if nobody in your family ada breast cancer, does that mean you will not get breast cancer? Tak juga. Because there are other risk factors. For example, you know, your estrogen level, dan kadang-kadang sel tissue, saya jawab bahasa Melayu jugalah in case macam ni, sel kita tak semestinya kerana genetik saja dia bertukar menjadi kanser, boleh juga disebabkan oleh perkara faktor-faktor lain. So tak semestinya tiada sesiapa dalam family you ada breast cancer you terselamat, masih ada risiko, dan kajian menunjukkan antara risiko-risiko tu ialah hormon level. Perempuan zaman dulu dia mengandung 9-10 anak. Kita sekarang mengandung seorang, 2 orang. So, bilangan kali kita mengandung pun ambil risiko juga. Maksudnya, kalau you tak pernah mengandung, you pun ada high risk of breast cancer. Menyusu badan melindungi you. Kalau you pernah menyusu, you akan kurang risiko dapat breast cancer. Again, malangnya kita sekarang ni, sudahlah mengandung pun tak berapa banyak, menyusu pun tak berapa jugalah automatically. Jadi again itu pun predispose kepada breast cancer. Ambil oral contraceptive pill, hormone replacement, itu semua pun memberikan risk untuk develop breast cancer juga. Dan pemakanan tu, okay. Pemakanan berkait rapat dengan obesity. Sesiapa yang obese, maksudnya BMI dia tinggi, dia ada high risk of breast cancer. Kenapa? Kerana fat tissue tu ada menghasilkan hormon estrogen yang boleh menggalakkan pertumbuhan breast cancer lah. So that's why one of the modifiable risk factor that I've explained earlier termasuk berat badan. Jika you ada obesity, ada risiko untuk develop breast cancer. So saya harap ini menjawab soalan you lah. Makanan tu directly towards obesity lah in this case. Okay, Lynn, back to you.
Okay. Thank you so much, Dr. Nazimah Mumin, for a very, very good explanations when it comes to the mammogram screening and also how to detect the breast cancer and everything. Hi everyone again. To those who just joined, my name is Linda Abdul Wahab. I'm the host for today virtual health talk, empowering women to a greater healthcare. The first presenter just now is Dr. Nazimah, and Dr. Nazimah is a very well-versed and very experienced in terms of breast imaging and radiologist. Yeah. So to those who would like to know further and also to do the screening, you may visit UiTM Private Specialist Center and seek for Dr. Nazimah. Aside to those who just joined, there is a good news, a very, very good news. Okay. You have to stay tuned until the end of the second session of this so that we will provide you a special rate or a link for you to register to our special rate.
Emailnya yang kenali.
Okay. All right. So without further ado, let me hold on. Let me just check who is online. Hold on. Okay. To those who would like to ask questions, you may write in the chat box later. And without further ado, I would like to actually introduce to all of you our second presenter, which is our very special Dr. Noorneza binti Abdul Rahman. Dr. Noorneza is a medical graduate from University Malaya in the year of 2002, pardon me, and completed her master in obstetric and gynecology in the year of 2010. She has special interest in minimally invasive gynae surgery and robotic surgery. Her current post is a consultant in obstetric and gynecology, UiTM Private Specialist Center, and also a senior lecturer in faculty of UiTM. Okay, and indeed a very well experienced as well, with more than 20 years of within this field of more than 20 years of serving the society as a whole. Assalamualaikum, Doktor. Apa khabar, Dr. Noorneza?
Waalaikumsalam. Can you hear me?
Yes, we can hear you clearly, Doctor. Doctor, perhaps you can explain a little bit or maybe introduce a little bit about yourself, a very short bio, and also after that you may proceed for the virtual health talk on the basically on the gynecology screening.
Assalamualaikum and a very good afternoon. I think Lynn already introduced me. So I'm Noorneza and I'm actually obstetrician and gynecologist. And I'm working with UPSC at the moment. So I hope that you will gain something today. And this is actually very good for us to actually empower ourselves and make sure that we know about our body. Lynn, I will proceed, yeah?
Yes, okay. Doctor, you may do so.
All right. So if you want me to mix, I will mix between English and Malay. But if you are okay, we can proceed with English, right? So basically, when we talk about gynecologists, right? So basically, today I'm not going to talk about pregnancy. It's more about our reproductive organ. And when we talk about screening, it's actually looking into the cancer, right? So screening is always about preventing a disaster or a major disease, which is a cancer. And on top of that, at the end of the talk, I am actually going to give some input in terms of benign gynae disease, which is actually also debilitating and actually has affect more women nowadays, okay? So when we talk about gynecological screening, right, we are talking about the ovarian tumor, which is cancer of the ovary, cervical cancer, cancer of the cervix, or in Malay we call it pangkar rahim, endometrial cancer, right, is a cancer of the lining of the womb, meaning within the uterus, within the rahim, where this is where the menses is being produced, the lining of the womb, okay? And then we talk about benign disease. This is called as endometriosis or adenomyosis. We will go one by one. So we'll start off with ovarian tumor. So sorry for the features, for the picture. So this is an example of a big or huge ovarian tumor from a patient. So why we need to talk about ovarian cancer? Majority of ovarian cancer, it is actually picked up when it is already stage 3 and stage 4, meaning it is actually a disease where the chances of survival is actually very limited. And for women, the lifetime risk of ovarian cancer is about 1 in 70 women. So when we talk about women cancer in Malaysia nowadays, the first most common cancer is the cervical cancer, which is cancer pangkar rahim, the endometrial cancer, which is cancer dinding rahim, and the third most gynae cancer is ovarian cancer. So what are the risk factors? All right, risk factors mean what will predispose you to this cancer. Number one, early menarche. Early menarche is period datang semasa umur yang muda, maybe daripada 9 tahun, 10 tahun, or when you have your menopause late, in which Malaysian women, the menopausal age is about 51 to 52 years old. So if you have menopause, if you menopause more than 52 years old, so there is still risk of ovarian cancer, increased risk of ovarian cancer. Obesity. Right, obesity is the commonest cause for all diseases, and also it is one of the risk factor in ovarian cancer. And after you listen to Dr. Nazimah just now, right? So anybody or any family history of breast cancer, this is actually related to family or genetic predisposition, right? Or family history of ovarian cancer. Therefore, you are at risk of ovarian cancer. So if a woman has the first degree relative of ovarian cancer, the risk of them having cancer is about 4%. If two of the first degree relative has cancer, it is, If two of the first degree relative is affected, and the risk is actually increased to 7%. And as you know, Angelina Jolie, who had this so-called genetic predisposition, so she removed her uterus, she removed her ovary, because when it comes to genetic predisposition, and if there is actually present in the line in the family, there is a presence of hereditary ovarian cancer syndrome, which we look into the genetic study, the chances of them having ovarian cancer is very high. Therefore, in UK alone, they will suggest that any women with this positive BRCA1 and BRCA2 to actually remove their ovary after age of 35 years old if they have completed their family. So, what will actually prevent you from getting this ovarian cancer, right? This is actually more of how we can actually allow ourselves or put ourselves into the screening. So who actually has a protective effect, who actually needs screening earlier, right? So whoever is using contraceptions, the pill, right? They have about they have a protective effect if they are using the contraception for 3 to 5 years. And patient who has tubal ligation, the risk of ovarian cancer is reduced. And if people has so-called surgical removal of the ovary, the risk of developing cancer is reduced by 80%. And in a family where they have this genetic positive BRCA1 and BRCA2, when we talk about genetic, familial genetic diseases in breast cancer and also ovarian cancer, we can actually somehow screen and identify by using a scan, a transvaginal scan, meaning a scan below from the vagina. And also we look at the tumor marker. That tumor marker, we are talking about CA125. Okay, CA125 is a tumor marker that can actually be elevated if a patient has ovarian cancer. And nowadays, it is good that we can actually identify the genetic or the predisposition, the familial genetic abnormalities to actually identify who is at risk of ovarian cancer. For example, if you have one of family members who has breast cancer, another family members has ovarian cancer, therefore you must actually go for the genetic testing to identify your risk of developing these diseases. And if we detect it earlier, we can prevent disease progression. So what are the screening methods that are available that we can offer all patients who is actually at risk or who wants to actually screen themselves? So when it comes to gynae examination, I know not many people like to be examined, but that's the only way for us to help you, right? So when you come to see us, we will take history, we will do pelvic examination, we will take blood for tumor marker, and on ultrasound, we have to perform a specific transvaginal ultrasound, not from the abdomen, but through the vagina. Or we have to do what we call multimodal screening, meaning we are not just doing one examination, we may at least 3 examinations to make sure that we don't miss anything. And nowadays, in terms of advanced medical science, they are now actually studying on proteomics to try to identify these diseases earlier. So what is pelvic examination? So when you see obstetrician, you have to actually being examined some sort in this position, what we call it lithotomy position. Therefore, there will be hand within the vagina that will examine presence of any mass in the uterus, mass in the ovary, or mass within the pelvic cavity. It is actually not painful. It is actually bearable, but there are certain factors that make it painful, right? So sometimes when you lift up your buttocks, you contract your muscle, therefore it becomes painful, but majority of the time it is bearable. So what we do during our pelvic examination, apart from the hand examination, we are putting this probe, what we call as transvaginal scan, where using this scan, it is directly, we can actually observe the ovary. So this is an example of an ovary, which is in a polycystic ovary, where there are so many follicles at the periphery. And this is an example of an ovary which is disease, right? So when we have something which is whitish or look solid within, so we have to think about malignancy. And this is a typical features of ovarian malignancy, where there is so many things inside. And we call this is a septation, multiloculated, right? Or there is capillary projection like here. So this is a typical features on ultrasound that tell us most likely we are dealing with ovarian malignancy. Without a pelvic ultrasound, it is difficult for us to see the ovary. Therefore, it is a must for a pelvic ultrasound. And in terms of tumor marker, we will actually advise the patient, and the most common tumor marker that actually we usually have to take in terms of ovarian malignancy will be CA125, CEA, and CA19.9. This is non-specific, but this will add on into the risk criteria of patient who comes to us with ovarian mass, with ultrasound findings of possible malignancy, and elevated markers will suggest most likely we are dealing with malignancy. So this is an example of ovarian tumor, which is big, about 10 centimeter, right? Taken out and sent for histopathological examination. Okay, so we move on. Now we are talking about cervical cancer, which is cancer pangkal rahim. So this is the third most common cancer in women after breast and colorectal cancer. And cervical cancer is actually, if it is detected earlier, the prognosis or the chances of you getting severe disease stage 3 and 4 is actually very much reduced. That's why we are doing screening for cervical cancer for so long. If you see, this is actually very old data, right? Over 40 million new cases of cervical cancer in 2012. And without screening, it actually will be increased. And furthermore, in our country, women are so shy to come forward. If they come, I mean, it's very sad. Sometimes when they come to us stage 3 and stage 4, the prognosis may be about only, you know, I mean, we just can tell you numbers, maybe 6 months, maybe a year. But if we detect it earlier, it is actually, the prognosis is actually very good. I will tell you how. I will tell you why it is actually easy. It is actually very good if you, whoever is sexually active, come forward and that and have a screening pap smear, then we can assist you throughout. So for Malaysia, the lifetime risk of cervical cancer about 1 in 116 women. So in 116 women, 1 will develop cervical cancer. So what are the age? What are the age? So the age is about 40 to 60 years old. That's the peak. And then throughout, it will decline until 70 to 80. But after 80 years old, there is an increased risk again of developing cervical cancer. So we are talking about here. This is the cervix cross-section. So this is how we look from the speculum examination. If Malay, usually they call it that mulut itik tu, the speculum examination. Okay. So when you look at the cervix should look normal, smooth. There is no growth like cauliflower. Okay. So if there is actually changes somewhere here, all right, and we don't see it, we will miss. If you can see, this is very small lesion, okay, less than 2 mm. So it is early stage. But we don't want to pick up you at this stage, not you. I mean, we don't want to pick up patient who has cervical cancer at this stage. We want to pick up earlier before it develops cancer. So when it is already more than 5 mm, stage 2, Stage 3, it goes into the pelvic cavity and the cells surrounding it, the vagina, the support here. And when it comes to stage 4, it already goes to the bladder and also to the bowel. Okay, so what causes CA cervix? What causes cervical cancer? So it is well known that human papilloma virus infection is the culprit that causes cervical cancer. So what happens in a woman who is sexually active, the moment they have sexual intercourse, the possibility of infection is actually very high, right? So this is purely because of sexual intercourse. The man can be infected with human papilloma virus, and the infection in the patient, supposedly this virus, if it goes into the cells in the cervix, if it goes into the cervix, so using our immune system, majority, more than 90% will actually cure the disease. However, 10% of patients, they will have persistent disease. So if this persistent disease by persistent viral infection, it is not detected, it is not treated, there will be progression. Progression, it will lead to changes in the cells. This is already, there is presence of changes in the cells. It can lead to precancerous lesion. So if we pick up during infection, if we pick up during precancerous lesion, the survival rate is very good. But if we don't do anything 10 to 15 years along the line post-infection, it will lead to cervical cancer. And this is actually very bad because patient can have very foul, smelly, vagina discharge, busuk sangat. They will have bleeding. They cannot, it will damage the kidney because the disease actually affect this part where there is a ureter, saluran kencing yang pergi ke punya kencing here, you know, the ureter that come into the bladder will be affected by this cancer and will cause kidney disease. So sometimes these patients, they don't really die because of cervical cancer, but they die because of end-stage renal failure, the kidney disease itself. Okay, so what to do? What to do? Easy, I mean easy, very easy actually, but you just need to come. You have to put away the shyness, you know. Women well, we want to help. So if you can see, number 2 is HPV vaccination. Okay, healthy lifestyle actually is meant for everybody, every diseases, meaning not multiple sexual partner, single partner, no anal sex, no other sex, it's just a sex. Or in a primary prevention, we're talking about prevention to get this HPV infection. So sexual abstinence, meaning whoever is not sexually active, the risk of HPV infection is much less. So that's why nowadays we actually vaccinate our girls, right, with this so-called human papillomavirus vaccination, so that they have a very good immunity. So if they were infected later in their life, the moment that they are married, so they will reduce the chances of prolonged infection by the virus. In other countries like Australia, they actually vaccinate the male as well, because as I mentioned, this human papillomavirus infection is actually come from sexual intercourse. Therefore, the boys is also the boy or the man is actually passing the infection to the wife or to the partner. Therefore, nowadays, we would like to make sure that all women, and if possible, the boys as well, to get vaccinated when they are young, 13, 14, 15 years old, before sexually active. So that is the best that we can do to prevent this cancer. And when we come to secondary prevention, okay, secondary prevention is actually detecting a lesion before it becomes cancer, the precancerous stage. So this is where it comes, the pap smear, the other screening that I will tell you afterwards. And in tertiary prevention, it is already early stage of cancer, but still we want to get it early when it is stage 1 rather than 2, 3, and 4. So what we do during the screening? So this is the speculum that I mentioned. Okay. So when women came forward, we will examine, we will look at the cervix, pangkal rahim, and we will use this brush, right? We will use this brush. This is the latest technology. Sorry, this is LBC, actually, liquid-based cytology, not V. So we actually use the brush to get the cells from the cervix and we send it to be read by the cytologist. Therefore, we will get the cytology. Then it will tell us whether this is actually normal cells, whether this is a precancerous cell, whether there is already a cancer. And the good thing nowadays, we have HPV test. HPV is human papillomavirus test, where it can detect the high-risk virus and the low-risk virus. And we know who are the patients who are at risk. For example, if you do the liquid-based cytology smear and you do the HPV test, if all negative, your screening for cervical smear can be done 5 yearly. Right? If you do the pap smear without HPV, the screening will be first 3 consecutive yearly, then after that 3 yearly until age of 50. So I will suggest, right? I will suggest to my patient to take this test because if the patient has high risk human papillomavirus, we have to monitor patient closely as compared to patient without human papillomavirus. Therefore, if we detect abnormalities on the screening, we will proceed with more, this is like screening plus treatment, screening plus possible treatment, where we actually will detect presence of precancerous lesion. When we do this examination, which is speculum cytology, we are looking with our bare eyes. But when we do colposcopy, we are using a magnification glass to see the cells at the cervical area where we put certain solution, then it will pick up abnormal area. And when we pick up the abnormal area, we can perform a biopsy. Then we will get a proper diagnosis. Okay, so I move forward to endometrium cancer. This is a cancer of the lining of the womb. Majority, it is after postmenopausal age group. But somehow in recent years, because of obesity, about 20 to 25% were diagnosed before menopause and 5% below age of 40. And as I mentioned earlier, this is the third commonest cancer in Malaysia after cervical and ovarian cancer. What are the risk factors? In endometrial cancer, we don't have a very effective screening method. Therefore, all women must actually have some knowledge and they must come forward to be screened. Right? Who are at risk of endometrial cancer? When the woman has prolonged exposure to hormone, women hormone, estrogen. For example, in PCOS, polycystic ovarian syndrome. So this woman has higher tendency to have changes in the lining of the womb from normal to precancerous and to cancer. Patient with hypertension, diabetes, obesity, never pregnant before, late menopause, and who presented with heavy perimenopause bleeding is at risk of endometrial cancer. So what are the screening that are available for endometrial cancer? So we are looking at the patient age. For example, in a postmenopausal lady, where there is a postmenopausal bleeding, do not wait. Come immediately, then we will perform the transvaginal scan. So this is features or a scan showing that the lining of the womb is thin, and when we scan, it should be less than 4 mm. As compared to this scan, right, if you can see, this part is actually thin. However, at the fundus here, it is actually thick. So in a menopausal lady, if it is thick, we must take a biopsy to make sure that we are not dealing with cancer. It can actually come back just as a polyp. So this is actually hysteroscopy pictures of a patient where we put a scope into the womb, into the uterus, and you can see there is a bulging here. So this is a polyps. This is also angry looking polyps with all blood vessels. And this is actually pre-cancerous lesion inside the womb. The womb should be just nice like this, not thickened, and you cannot see anything inside. Therefore, you have to look at the predisposing factor. You have to look at the genetic. Therefore, in in endometrial cancer and also in ovarian cancer, the moment that your parents or any sibling who has ovarian cancer, breast cancer, endometrial cancer, you should be screened. You should come forward and get a screening by us. Okay, then come to a benign disease. This is endometriosis, where the lining of the womb is actually present in the ovary or inside the cavity, where patient usually has very painful menses, and the painful menses is worsening. Patient has difficulty to conceive, to get pregnant, and when they have sex, they have severe pain during sexual intercourse. And in some patients, they have heavy menstrual bleeding, right? So this is actually a features of an ultrasound. When we do screening for this patient who has all those symptoms, there is an enlargement or there is a cyst in the ovary, right, that suggests presence of endometrioma, chocolate cyst. If we operate, there will be like chocolate material that come out from this ovary. And if we don't treat, we know that nowadays there is a tendency of endometriosis or endometrioma to actually develop into ovarian cancer in later life. And as compared to this side, this is the uterus, this is the womb. So the endometrium lining supposedly stays in the endometrium cavity. But if the cell actually present in the muscle itself, every time when women have menses, there will be blood accumulation inside here as well, like a menses but trapped in between the muscles. Therefore, the patient has severe pain, heavy menstrual bleeding. So these women suffer, and usually they don't come forward. When they come to us, it's already late that we cannot be safe. We have to actually remove the uterus. So what can be done? Same. All these patients need a scan from the vagina, from below, and also a tumor marker to assist us, because it's in endometriosis, the tumor marker CA125 actually can be raised. Okay, I think that's it. That's it for the presentation.
For any questions, we open the floor right now. You may type your questions in the chat box. Doctor, I have a question. For example, for a woman, yeah, if there's a lot of discharge, what do we call keputihan, which is over discharge, terlalu banyak, is it a sign, one of the sign yang boleh membawa kepada, ovarian cancer or something similar, or maybe any abnormalities?
If we are talking about vaginal discharge in young women, in a sexually active women, where the discharge is actually sticky, curdy, itchy, so most likely we are dealing with an infection. However, if in a patient where the discharge is watery, a lot, and smelly, so that is also a features of it can actually happen or present in a patient who has cervical cancer. And if in a postmenopausal lady, that discharge can actually suggest endometrial cancer. Therefore, any discharge that is not normal to you, you need at least investigation or we can call it screening to make sure that we are not dealing with cancer. A cancer, yeah. I don't see a question in the chat box. Lynn, can I pass to you? I don't see a question in the chat box.
Okay, can. Shall anyone have questions with regard to gynecology, screening, or maybe ovarian cancer or any related gynecological diseases? You may write the questions in the chat box.
Hello, Doctor.
Yes.
Hi, my name is Sarwara. I couldn't find the chat box button, so I just unmute.
Yeah, you can ask.
Yeah, I want to ask about the PEP test. After we have done the test, will we be like bleeding out of the vagina?
Okay, majority of the time, no. But in certain condition where there is what we call as ectropion, meaning there is in the cervix, there is actually a little bit exposure of the lining, which is supposedly to be inside the cervix. When the cervix is actually exposed like that, then when you do smear, there is a risk of bleeding, but that bleeding shouldn't be much. It is just like a staining rather than a profuse bleeding. So majority of the time, pap smear should not have bleeding. But in certain condition where the cervix has some changes, yes, bleeding can happen. Do I answer your questions?
Yes, you do. Thank you so much.
Okay, there is one question from Natasha. Basically, doctor, what are the process after patient diagnosis of ovarian cancer? Okay, the moment that we have a patient where there is an ovarian mass on an ultrasound, so we have to actually perform the blood investigation, and we will do staging using a CT scan. Right. So following that, we will see what are the stage of the disease, and the management is purely depending on the stage of the disease, where early stage, stage 1, stage 2, maybe stage 3, there will be surgery followed by possible chemotherapy or radiotherapy. Okay. Fazila also ask a question. Saya ada endometriosis selepas buat laparoscopy, still sakit masa period. Do I need to do screening? Okay. Bila kita cerita pasal endometriosis, seriously, I am actually very, orang kata, sangat-sangat mengalu-ngalukan ataupun bukan. Saya sangat-sangat memerlukan pasien-pasien endometriosis ni untuk tahu. Endometriosis adalah sesuatu yang you memang kena ada follow up, because kalau tak ada follow up, disease akan berulang. Endometriosis tu akan berulang. Bila endometriosis tu berulang, dia akan menyebabkan bengkak balik, dia akan menyebabkan jadi balik, and kita tak suka nak operate orang lama-lama. Therefore, orang-orang yang endometriosis ni, kita sekarang ada satu ubat yang kita panggil Visan ataupun Dynagest. Ubat ni adalah sangat bagus untuk menghalang endometriosis daripada berulang, dan bila kita halang dia berulang, kita rawat dia, sakit pun akan jadi kurang. Dan seperti saya cakap tadi, satu benda yang pasti, endometriosis ni ada tendensi untuk bertukar menjadi kanser. Therefore, orang-orang endometriosis dia tak boleh lari daripada follow up. Right? They have to come back, and at least you need 6 monthly or yearly screening. Yes, you need to come. Okay, Fazila, saya dah jawab soalan Fazila. Right, so doctor, at what age is suitable for ultrasound to do the screening? Okay, this is a good question. If we come to an ovarian cancer, if it is ovarian cancer, if you have a family members, first degree relative, mother, sister, auntie who has ovarian cancer or breast cancer, ataupun dah confirm you have genetic hereditary cancer, therefore you need to come as early as possible, and that screening will be like yearly screening or 2 yearly screening to make sure that there is no changes in the ovary. But ours are just yearly screening. Okay. For postmenopausal bleeding like for endometrial cancer, the age will be after postmenopause. But whoever has all those risk factors, PCOS, obese, hypertension, diabetes, so they should be, and plus if there is abnormal bleeding, they can be screened as early as possible. So I cannot give you a specific number for screening. It's totally depending on the history and also on the presentation. But if you are sexually active, we can screen you from the vagina. If you have a family members who have or the relative who has like ovarian cancer, we can actually, and if you are not sexually active, we can do ultrasound from the anus to actually see the ovary. So any age is actually suitable. Okay, no Lin. Oh, that is from Lin. Okay, Rabiatul, adakah normal kalau period keluarkan lendir coklat yang banyak, bukan seperti darah beku period? Okay, so Rabiatul, period should be normal like period. So sekiranya kalau ada perubahan kepada warna ataupun rupa dan you rasa benda tu tak biasa, so boleh sebenarnya datang untuk diperiksa dahulu. Then kita boleh bagi bantuan sama ada, okay, ni adakah Amin adalah normal untuk you ke ataupun sebenarnya tak normal. Sebab darah period dia tak sepatutnya berlendir, dia lebih kepada not like jelly as well, what we call it. It should be normal flow without much of discharge. Dan dia tak sepatutnya berketul-ketul. Orang yang ada darah period yang heavy dan berketul-ketul tu sebenarnya tak normal. Yang itu memang kena check. So kalau Rabiatul tak tahu, tak sure, maybe kita boleh check lah. Okay. Okay, Lynn, I see there is no more questions. Fadila is saying thank you. Thank you, Fadila, for asking. And thank you for everybody who's asking and listening.
Thank you so much, Dr. Noorneza Abdul Rahman. Okay, Dr. Noorneza is actually a very specialized in gynecology and also in obstetrics. So you may want to visit Dr. Noorneza in UiTM Private Specialist Center because she will provide a very extremely good advice to those who have abnormalities and also perhaps any diseases. Yeah. All right. Thank you so much, Doctor.
Thank you, Lynn. Thank you all.
To those who are still here, thank you so much for joining our virtual health talk today. Now, I will pass you in the chat box the link for those who actually wanted to do the mammogram screening with our special rate. Yeah, just hold on, give me a moment. Perhaps you want to consider the mammogram for your sister, for you yourself, for your mom, perhaps your husband. You want to give this mammogram special rate to your wife, maybe to your mother-in-law. You may proceed to do so as well. There's no issues on this, and only those who are actually here will get this special rebate. Yep. And I will as well send an email for this special rebate to all of you that join. All right, that's all from us today. We will actually repost this virtual health talk in our social media. So for those who want to ask any questions, for those who would like to know further about our mammogram and our gynecological screening, you may even ask us in social medias. You may contact us, call us via through my emails that I sent you earlier, or you can even contact us through our direct line. All right, that's all from us. Thank you so much from UiTM Private Specialist Center to everyone that joined today. Bye. And we hope we do give you a very good informations for this round of virtual health talk. Let's empower women to a greater healthcare. I will do myself as well, I guess. Thank you so much for joining. Thank you. Thank you.
Hello.
Thank you. Yes, there will be more sessions coming in, perhaps this time around for men healthcare, perhaps for more of the topics that you would like to know, like COVID-19, the post syndromes and what to do and all. Thank you so much. You may leave the room as of for now.
Selamat datang kat sini. Apa ni? Oh, Zina. Zina ni. Commercial. Marketing. Betul, oh ya. Siapa yang charge untuk ni besok? Idea dia? Okay, tak apa. Okay,
See you again next time.